Good morning, good afternoon, good evening, everyone. So, as you know, that we are into our sixth episode of Virtual Bariatric University, and I, Dr. Vinny Mathur, bring greetings from Mohit Bariatrics and Robotic Surgery Center, Indore, India. It is my honor today to introduce you all to yet another subject in the field of bariatric and metabolic surgery, which is much debated upon, although sufficient data exists to support this procedure. Yes, I'm talking about the improved version of gold standard in bariatric surgery, the banded gastric bypass. The band application has been going on over the years and it is not a novel concept, but it's been practiced since ages. Professor Mathias Fobi banded most of his gastric bypass procedures because he had data to support that the weight maintenance in the long term is excellent. We at Mohawk have also performed more than 4,000 procedures with bands, and banded gastric bypass being largest in number. And we have good long-term data on this procedure. It's my honor now to introduce you to the faculty of this particular webinar. We have with us Dr. Everton Cazzo from Brazil, one of the prominent bariatric surgeons. He is the digestive and bariatric surgeon, adjunct professor in the Department of Surgery and Faculty of Medical Sciences at State University of Campinas. He did his master's and doctorate degree from the same university. He is a fellow of IFSO and a Brazilian Society of Bariatric and Metabolic Surgery and Brazilian College of Surgeons. He is a researcher on bariatric and metabolic surgery and hepatobiliopancreatic surgeries. His main fields of research are banded gastric bypass, banded anastomosis gastric bypass, and also some studies on insulin resistance. I welcome Dr. Cazzo. Then we have with us Dr. Arthur Garrido from Brazil. He's one of the father figures in bariatric metabolic surgery who has the distinction of leading the world. He's an associate professor of gastroenterology and digestive surgery, University of Sao Paulo Medical School. He was the founder and ex-president of the Brazilian Society for Bariatric and Metabolic Surgery. He was also the ex-president of IFSO. He is the director of Instituto Garrido for Surgical and Multidisciplinary Treatment of Obesity at Sao Paulo. I welcome Dr. Garrido. To add more to this evening, we have Dr. Khaled Gawdat from Egypt, who has maximum experience in performing banded procedures and standardizing it. Dr. Khaled Gawdat is the pioneer of morbid obesity surgery in the Middle East. He introduced obesity surgery to Egypt in 1996. He has extensive experience with all types of obesity operations. He was the founder of the Egyptian Society for Bariatric Surgery, president of the ESFBS in 3 different years, and he's also on the editorial board of obesity surgery and Egyptian representative in IFSO since 1999. I welcome Dr. Gawdat. We also have with us Dr. Jean Greve from Netherlands. Dr. Greve serves as a medical director of the Dutch Obesity Clinic South and chair of the Metabolic and Bariatric Surgery Unit at the Zuiderland Medical Center in the Netherlands. Dr. Greve has received his PhD at the Academic Hospital in Netherlands and has served on numerous committees, supervised 15 doctoral theses, and authored more than 185 peer-reviewed papers and numerous book chapters on intensive care medicine, nutrition, and bariatric and metabolic surgery. He was the principal investigator of 2 European endobariatric clinical trials and other single-center and multi-center trials. I welcome Dr. Greve. I'm honored to introduce you Dr. Miguel Herrera from Mexico. Dr. Miguel graduated and completed a 5-year residency program in general surgery at the Instituto Nacional de Ciencias Médicas y Nutrición del Salvador Zubiran in Mexico City and received the PhD degree from the UNAM in 2001. He is currently a staff surgeon at the INCMNZ and professor of endocrine bariatric surgery at the UNAM. He is a member of 7 international associations and co-editor of obesity surgery. He is also the president of the Mexican College of Bariatric and Metabolic Surgeries, and he has published 195 papers in peer-reviewed journals, 89 book chapters, and 6 manuals and 6 editorials. I welcome Dr. Herrera. We also have with us Dr. Mahendra Narwaria from India. He's a director at the Asian Bariatric Sun Cosmetic Private Limited Center, Ahmedabad. He was the past president of the Obesity Surgery Society of India. He was also the vice president of All India Association of Advancing Research in Obesity. He was past president at the Association of Ahmedabad Surgeons. He's a general member council at IFSO, and he is a credential committee member at Asia Pacific Bariatric Center, IFSO. I welcome Dr. Narwaria. Dr. Fobi and Dr. Bhandari are our co-directors of the course. So let's start the show without any further delay. I would like to invite Dr. Garrido and Dr. Miguel to moderate our first session. Dr. Garrido.
Well, good evening, and it's a pleasure to be here with you today, and I congratulate with this kind of meeting, which is essential nowadays. In order to save time, I'll just invite my colleague moderator, Dr. Miguel Herrera, to introduce our section and present whatever he wants to show us. Dr. Herrera.
Thank you very much, sir. Thank you very much, everybody. It is a real pleasure to be in this important session. And we will be discussing the Bhandari gastric bypass for the following 90 minutes. So I think we can start with the first presentation. Dr. Garrido, would you like to introduce the first presentation?
It's yours. Oh, wouldn't
okay.
You? You let it to the end, right? To comment?
Yes.
Okay. Then
Dr. Cazzo is coming.
Everton, Cazzo, he'll present a prospective report with 10 years follow-up on banded gastric bypass. Dr. Everton Cazzo is from University of São Paulo in Campinas. It's called, right? And he has a large experience and will help us with this presentation. Dr. Everton.
Hello, everyone. It is a privilege to have the opportunity to make this presentation for this highly qualified audience, and also to be beside such luminaries of bariatric surgery. Does everybody see my presentation? Is it okay?
Yes, it's okay.
Let's go. It is entitled Banded Gastric Bypass, a prospective report with 10 years follow-up. I have no competing interests. As all of us know, bariatric surgery has become the gold standard treatment modality for refractory morbid obesity. Nonetheless, both weight regain and surgical weight loss failure remain as two important concerns. Because of the relevance of this topic, our group, under the leadership of Professor Pareja, designed a study that was published in CERD a couple of years ago. And the main objectives of this study was to evaluate weight loss outcomes after banded Roux-en-Y gastric bypass on a very long-term basis of 10 years, with a focus on weight regain and weight loss failure. The study was designed as a prospective cohort study, which enrolled 928 individuals who were operated on from 1999 through 2006 and were followed up for 10 years at a private healthcare facility. The main characteristics of the banded gastric bypass were a 30 milliliter gastric pouch, which was created through calibration with a 36 French Bbu during the procedure, along with a 100 centimeter biliopancreatic limb and a 150 centimeter alimentary limb. We used a 6.5 centimeter silicone ring which was placed 2 centimeters above the gastrojejunostomy. Weight loss was evaluated by means of 2 main variables: percentage of excess weight loss and percentage of total weight loss. Surgical failure was considered according to the Reinhold criteria, that is, the presence of a body mass index above 35 kilograms per meter square, or a percentage of excess weight loss below 50% in the morbidly obese individuals, or a BMI over 40 kilograms per meter square, or a percentage of excess weight loss below 50% in the super obese individuals. We used a statistical method called generated estimating equations, which is based on an unstructured matrix and is designed for analysis with varying proportions of follow-up over time. We observed that in the morbidly obese group, the minimum BMI was achieved around 18 to 24 months. Then there was a slight weight regain until 60 months, followed by a steady stability until 120 months. In the super obese, the results in regard to BMI were close to this, but with a tendency to a later weight regain, around 8 to 10 years. In regard to weight loss, the morbidly obese group presented the maximum loss around 18 to 24 months, then presented a slight weight regain, and the weight loss tended to stabilize from 60 to 120 months. Similarly to what we have seen in regard to BMI, the super obese group tended to present some later weight regain, around 8 to 10 years. Comparing the occurrence of weight loss failure, we observed that the best results for the morbidly obese were also achieved from 18 to 24 months, with a slight worsening until 60 months, and then no more changes in this variable. In the super obese, there was a more pronounced later worsening. However, the proportion of individuals classified as failures did not significantly differ. Analyzing the band-related morbidity, we observed that the occurrence of bone slippage or migration was present in 11 individuals, which accounted for only 1.2% of the entire cohort. We consider that the major findings of our study were a strong tendency towards maintenance of weight loss from 5 to 10 years after banded Roux-en-Y gastric bypass, along with low rates of weight regain and surgical failure in the morbidly obese, and slightly higher rates of late weight regain and surgical failure in the super obese, as well as a low frequency of band-related complications. In our opinion, we attributed this tendency towards very long-term weight stability to banding the gastric bypass. Other authors have observed close results. Lemons, in a 2-year follow-up, demonstrated that the proportion of individuals who did not present any weight regain was significantly higher among individuals who underwent banded gastric bypass in comparison with non-banded. Hinihan and collaborators also observed that the overall percentage of excess weight loss after 2 years was significantly higher in individuals who underwent banded gastric bypass when compared to non-banded. And this difference was even more pronounced in the super obese group. On our experience, we concluded that The banded gastric bypass leads to a significant and durable weight loss. The nadir weight is achieved around 18 to 24 months, with a slight weight regain until 60 months, and then a weight stability until 10 years. My final remarks are that banded Roux-en-Y gastric bypass is associated with a long-term maintenance of weight loss, and so bands should be always considered a valuable option in gastric bypass. Thank you very much for the attention and the interest.
Thank you, Dr. Everton. Congratulations. And should we discuss this paper or go ahead and discuss all together at the end, after Dr. Fobi's? I propose we go on and we discuss at the end, okay?
Okay, we'll do that.
Okay, then Dr. Fobi, please, what did we learn with your operation?
All right, let me see if I can share this screen. There we come. Are we there?
You have
You
to
having any
share,
problem?
you
Am I
have to
sure?
share the screen.
I did.
You did already? Okay, let me check.
Check and see.
Okay, we'll share it from our side.
Okay. I don't know why.
No problems. Can you see it now?
Just give me a minute. Let's see. I can get it from here. Is it? Can you get it now?
Why don't we discuss a little bit on Dr. Cazzo presentation?
Go ahead and discuss.
you get in,
Okay.
okay? Okay.
Thank you.
Would you like to comment something, Dr.
I'm
Miguel?
ready to go.
Oh, okay. Okay.
Let's go. All
Let's
right.
follow our program.
Thank you. Thank you all for coming for this session. My talk is really to emphasize the importance of doing a banded gastric bypass and what the responsibility of the surgeon is in order to have an effective procedure. What we have learned in about 30 years of banning the gastric bypass. Are you okay, bringing you greetings from Mohawk here in indoor. As you can see, that's the laser building is where we do most of the laparoscopic teaching. The big long building is the medical school and hospital. And then Mohawk High Tech is where Dr. Bhandari and I work. It's an exclusively bariatric surgery center where we do an average of 100 to 120 bariatric surgeries a month. Next. My only disclosure is that I'm the president of a corporation that produces rings. And I personally had a ring gastric bypass to treat my diabetes, which has been controlled now for 9 years. The case mix, currently we do about 1/3 sleeves, 1/3 banded gastric bypass, and 1/3 minimal OAGB, MGB, and a few revisions. Basically, there's a lot to learn. So those who don't take the time to review what has happened in the past are likely to make the same mistakes. And we're hoping that by having a session like this, we can talk about what we've known for 30 years and why we do what we do and what we've done to improve it. Next. The Roux-en-Y gastric bypass has been classified as the gold standard of bariatric operations. This operation was introduced back in 1967 and has stood the test of time. However, there's a tendency for people to regain weight because the pouch, the stoma, and the proximal jejunum dilates with time. And so patients who have this surgery with time can eat more than they were right after the operation. And in a subset of patients whose stoma and pouch dilate and they can eat more, they regain weight. Next. This is a drawing of a pouch that is dilated. You can see the pouch is dilated, the stoma is dilated, and the proximal jejunum. This becomes a reservoir. So in America, a patient who after surgery could take just a few bites cannot eat a whole hamburger and French fries. When you put a ring around that pouch above the gastroenterostomy, you restrict how much that pouch will dilate. In the first couple of months, the patient will not notice the difference whether they have a ring or not because that ring is placed loosely. But as the pouch dilates, the ring becomes restrictive and prevents it, so the patient does not form a big reservoir. So you can look at the picture here, you see the difference between a gastric bypass that is done with a band and one that is not done with a band. So the most important thing about the gastric bypass, the banded gastric bypass, is that you make a small, lesser curvature tubular pouch, about 2 centimeters in diameter and about 6 to 8 centimeters long, and place the ring a size 6.5 to 7.0 around that pouch, about 3 centimeters from the GE junction and at least 2 centimeters from the gastroenterostomy. And the ring has to be loose. It's very important if it's not loose. If it's not loose, you're going to have problems. And we learned that over a 10-year period, and now we very rarely have that problem. Next. This is a typical ring that is placed. You can see it's about 2 centimeters above the gastroenterostomy. The ring is loose and it's 3 centimeters from the gastroesophageal junction. Next. The functional pouch when you do this is less than 30 mils. Most times the ones I do are somewhere between 15 and 25. The rule limb is usually about 80 centimeters. Sometimes we can take it up to about 120. And the BP limb is anywhere from 80 to 120. We close all defects. That is very important when you do the banded gastric bypass. Next. This is what is important about doing the banded gastric bypass. The slide is moving. Himanshu, go back, go back, go back, go back, go back. Okay, this is what is important. You do a technically good operation, but you should spend time with the patient because a patient who has a regular gastric bypass, during the first 6 months to a year, the patient cannot eat much and the patient loses weight. And the reason the patient does that is because they have to eat slowly, chew their food thoroughly, and take small bites. So when you place a ring there, the patient has to do the same thing, but you let the patient know that what they experience during the first 6 months is going to be the same thing for the rest of their lives, and they have to live with it. So for the rest of their life, they have to eat slowly, take small bites, and chew their food thoroughly. Patients who have a gastric bypass don't complain about that because they do it and they do well. So you tell the patients that they will have dysphagia, they'll regurgitate the food, they'll vomit after eating. If they eat fast, if they do not take small bites, and if they do not chew their food thoroughly before swallowing. These are things you have to talk to the patients about. Next. Sometimes the patients will complain of substernal pain. It's almost similar to a cardiac incidence. Advise the patient when this happens, it is because they're either eating fast, they're taking big bites, or they are not chewing their food thoroughly. When this happens, the patient should stop eating. But if it persists, they should seek medical attention because it's difficult to differentiate that substernal pain from a cardiac event. Next. I'm sorry about this. Himanshu? For the best outcome with patients who have a banded gastric bypass, they must stop eating when they feel full. Patients must avoid eating and drinking at the same time. Patients should drink between meals and mostly water and very low caloric fluids. You cannot have this surgery and end up drinking a lot of Cokes, Sprites, and high caloric juice. You would ultimately defeat the operation. Next. We should instruct the patient that anorexia will be experienced by a good number of the patients after a banded gastric bypass. The incidence of anorexia is slightly higher around banded procedures. I think the band around the pouch does stimulate the vagal nerves and the gastroesophageal junction and then makes the patient feel satiated between meals. However, instruct the patient that they have to eat at least 3 times a day, whether they're hungry or not, in order to prevent hypoglycemic attacks. And occasionally they should snack between meals. Patients have to allot at least 30 minutes per meal and eat slowly, chew their food thoroughly, and take small bites. Next. So dyspepsia, regurgitation, and vomiting occurs when the patient is eating fast, taking large bites, not chewing the food thoroughly, or eating and drinking at the same time. Next. Banning the gastric bypass increases the weight loss in patients with superobesity, as Dr. Cazzo has already shown us, and superobesity. Most importantly, banning the gastric bypass minimizes weight regain after weight loss. And that is the main indication for banning the pouch. The weight loss increase is not as significant as the weight loss maintenance because the gastric bypass is not easily amenable to revision surgery. And when you ban it and minimize the weight loss regain, then you have less indication for intervention. Next. In my practice, we found out that the incidence of band erosion was less than 2%. I see Dr. Cazzo reported about a 1.6%. Band migration can be induced by repeated dilatation or stent placement. Most, if not all, eroded bands can be allowed to extrude spontaneously or be removed by endoscopy. And rarely do you need to do laparoscopic intervention to take out any band because of complications. That is why doctors doing a banded procedure should be aware of the endoscopic intervention when they have problems with the band. Next. Okay, as I said, the incidence of outlet stenosis, which is the most common problem, which is about 6 to 23% in the non-banded gastric bypass, is less than 1% in the banded gastric bypass. Mainly because when you do a banded gastric bypass, you do not try to make a narrow gastroenterostomy like in the non-banded gastric bypass. You normally make the gastroenterostomy, as you will see later today when Dr. Bhandari does it, at 2 to 2.5 centimeter wide. So these patients can eat freely right after the surgery. And they will lose weight just as in a non-banded gastric bypass, but after 1 year or 18 months, they will not regain much weight. Next. Similarly, the incidence of dumping after the banded gastric bypass is minimal because the rate of emptying from that pouch is less. And so patients have less incidence of dumping and therefore do not eat and then go back and eat and go back and eat. So that maximizes the weight loss. Next. There are patients whom we call grazers. That means these patients eat all day long. They just take small bites and they have a whole plate of food sitting by them and they don't stop eating. And they chew their food thoroughly, and then they finish a whole meal between 7 o'clock and 11 o'clock, and then start another meal at 12 and finish by 4, and start one at 5, and finish at 9 at night. So they almost take the same amount of food they were taking before surgery. In these patients, you can treat them by doing what is called distillation of the small bowel. And this would cause some malabsorption, increase in creatine stimulation. However, when you do this, the patient will lose weight, but you have to increase the amount of supplements the patients take and make sure you monitor these patients biannually for nutrient deficiencies for at least 3 years and then yearly thereafter. Next. Okay, whereas the food intolerance and altered food choice is responsible for weight loss, and patients who have the regular gastric bypass, some of them would lose this intolerance and choice and therefore gain weight. Banning the gastric bypass has been documented to maintain this food intolerance and altered food choice for more than 10 years. The result is better weight loss and better weight loss maintenance. And as stated, most of people who do a banded operation show that the incidence of inadequate weight loss, or what we call non-responders, or failures, which is a term I don't like to use, is less than 7%. Next. And we advocate that you consider banning the pouch in most gastric bypass if you do it, because the bypass is not that amenable to revision surgery. And if you ban the pouch in patients who are going to have a gastric bypass, you minimize the incidence of weight regain. And if there are any complications, you can treat them endoscopically. And therefore, you minimize the cost for revision operations. And you enhance the metabolic effect of the operation. Thank you very much.
Very well.
Thank you. I would like to thank the staff at Mohawk, with whom I've worked for the last 4 years. Go ahead to the moderators. Thank you. Sorry about the slides.
Fine. I think everybody could see them. Dr. Herrera, would you like to preside this panel from here on?
Thank you very much. First of all, I would like to congratulate both of you, Dr. Fobi and Dr. Cazzo, for the presentations. As you know, the banded gastric bypass has been used for a period of time, and there are several publications related to that. So what I would like to present this evening for you is two systematic reviews comparing the banded gastric bypass with the non-banded gastric bypass. The first one is by the group of Dr. Mahawar, and they were able to analyze 17 articles related. And what they found is that in the initial years, the weight loss is very similar in the banded and no banded gastric bypass, but there is a significant difference favoring the banded gastric bypass at 10 years. The group also found that the number of complications was higher when the band was made by Celastic. Here are the comparative results, and what is interesting to see is that the report of the difference at 10 years comes from only one paper. So the conclusion of this systematic review is that the banded Roux-en-Y gastric bypass is an attractive bariatric procedure with superior outcomes, particularly in super-obese patients. There is a definite complication rate associated with the band. The complication rate appears to be lower with the non-cislastic band, and that further studies are needed to evaluate the risk-benefit ratio to identify subgroups most likely to benefit from the procedure and to standardize the surgical technique. Then in 2018, Dr. Margoldis also published a second systematic review. This was based on 8 articles. And what he initially found in his group is that the complication rates were very similar between banded and non-banded gastric bypass in terms of leaks, obstruction, and vomiting. That the weight loss at 1 year and 2 years was very similar, but that the Gastric bypass had superior results at 5 years, but again, based only in one study. So the conclusions of this study is that the studies suggest that both procedures are associated with significant weight loss, remission of comorbidities, and also the raise of complications and mortality. And according to one two-arm analysis, the Gastric bypass was associated with higher excess body weight loss at 5 years. And then the results should be interpreted with caution due to the small number of patients that were analyzed. Today, we have heard a great presentation by Dr. Cazzo, where he analyzes 928 patients with a ring made of silicone with a very low morbidity, 1.2, and excellent weight loss. The questions that I would have for Dr. Cazzo are, first of all, were all the 928 patients followed for 10 years, or the number of patients followed at 10 years was less than that? Second, I would like him to comment on the resolution of comorbidities, and also if he performed a test for food intolerance or malnutrition in his series of patients. Again, I think this is a very informative and educative session, and we will learn a lot from both presentations. Thank you very much.
Well, Dr. Cazzo, would you like to answer to that question, Dr. Cazzo?
You are muted, Dr. Cazzo.
Yes, hello? Can you hear me?
Yeah.
Yes.
In response to the important questions that were raised by Dr. Herrera, in this study, because of its design, we couldn't approach all of these answers. But we have a similar study that was performed in another healthcare facility, a public hospital, and a university hospital, where the question of food intolerance was raised. And really, the results were not that good. We observed a frequency of food intolerance after gastric bypass in a 1-year follow-up of about 30 to 40%. And the major problem was not the overall frequency of food intolerance, but the types of foods that were affected. The intolerance was higher for red meat and also to rice, which constitute major components of Brazilian diet. But also, we observed that the individuals did not follow the dietitian's orientations. In regard to malnutrition, it was not a significant problem. In fact, what we observed is that there was some non-adhesion to the dietitian's orientations. But in regards to specific abnormalities in regard to malnutrition, there was no severe problems. We had more severe problems and more malabsorptive procedures, specifically when we performed biliopancreatic diversions. And the disturbance observed after bundled Roux-en-Y gastric bypass were not so prominent. And in regard to comorbidity resolution, we have not assessed this data for this study because the follow-up, as Dr. Herrera raised, was not constant over the entire follow-up. We have a variable number of individuals evaluated in every year of follow-up. And because of this fact, we use the DEE statistical method, which is indicated for this situation. This results in a poor quality data, but it was what we have available at that time with a follow-up so long. But In my opinion, based on what we have seen, both at the private healthcare facility and at our public healthcare service, banded Roux-en-Y gastric bypass leads to a significantly higher weight loss at the expense of some food intolerance. It is not avoidable, and that is the problem. And as such, not all patients are eligible for banded Roux-en-Y gastric bypass. The choice of this modality should be carefully made before surgery.
Dr. Everton, Dr. Herrera asked, the first question was about the 928 patients follow-up. Were those all patients followed up at the same time? Were there the original group or some of them were lost?
Some of the original group were lost during the follow-up. We started with about 800 patients were not on follow-up at 10 years. Because of this fact, we had to opt for not a linear analysis for the statistics. And that is a severe problem in bariatric surgery cohorts.
Yeah, that's true. That's everywhere.
May I put a remark on that? We have the Dutch obesity clinics in the Netherlands, where we have 8 clinics doing gastric bypass surgery, and our clinic is the only one doing the banded bypass. We now have more than 5-year follow-up with a more than 90% follow-up of all the patients. And you see a very significant difference in weight loss and weight maintenance over time. And this is really on large number of patients. I think we do about 12,000 per year in the Netherlands and 6,000 total in the Dutch obesity clinics, hospitals that are involved. So I realized that the studies that have been presented, in particular, of course, the meta-analysis, do show some poor results. But the thing is that when you look at the studies that are in these meta-analysis, it's really a complete mixed bag of different procedures. For example, the MOON study is using a pericardic patch as a ring. It disappears in time. So they have a very bad weight loss when you look at the results critically. So really, we do, of course, need larger numbers and bigger series, but the banded bypass is doing very well.
90% is great follow-up. Fantastic. Dr. Gawdat is around. I have seen him.
That
Yeah, he's there.
Khaled? Imanshu, is Khaled signing?
Yeah, he's there. He has to unmute.
He'll be back.
Okay. Arthur, I'm with you.
Okay. Oh, okay.
Hey.
How about the comment? Hello. Welcome.
Yeah. Hi, Arthur. How are you?
Fine. Would you like to comment on that presentation?
Yeah, I think it shows clearly what we're talking about the results of the banding on the bypass or whatever procedure. But the one other problem we have here is that we don't always put the same material and we don't put the same size. So sometimes the studies on the long term are unfair. Jan spoke about the material, and I would like to emphasize that the size makes a hell of a difference. Remember the study from Canada on the VBG, when they put a 4.5 centimeter band versus 5 versus 5.5, and the results were completely different. So I think we have to agree on a certain standard fixed size for the band so that we can better evaluate our results. In my experience, my follow-up at 15 years is 40%. which is not very good, but at 15 years, this is the best I could achieve. And I have seen significantly better weight loss maintenance at every time intervals, starting from 6 months, 1 year, up to 15 years. It's day and night. So in my practice, all my patients get a banded gastric bypass as the first oral redo procedure.
Okay. I'll comment a little bit on our experience in São Paulo. We started with gastric bypass in '93. And we started with banded gastric bypass. And we kept doing it as over 95% of our procedures, like today, up to 2006, when we abandoned the ring. We gave up the ring. Why? Because we had around 10% recovery of part or total or almost total, 10% almost total weight loss, 10% after 5 years. It's true that we have a poor follow-up. By that time, around 50%. And now it's worse. We have less than 50% presently. Well, why we abandoned the ring that we learned initially with Dr. Capella and then appropriated our technique after learning with Dr. Fobi. We started using 5.5 centimeters ring, silicone ring, and we kept increasing the size up to 6.2. It was never loose like you use now, Dr. Fobi. And all the rest is about the same, except that we used always biliopancreatic limb around 50 and 1 meter, and the
ruling
alimentary limb, not more than 1 meter. So, why did we abandon? First, we had a significant rate of long-term complications. We had slippage, serious slippage, chronic subocclusion, needing revision and take out the ring in 3% out of, well, we had by that time in 2007, we had 7,500 cases, but only half followed up. I suppose that those who had complication, they came back. So let's think it's not lost for follow-up those who didn't. Those who had the subocclusion, 3% and 0.5% of erosion. Possibly we had a very small ring at the beginning, and most of them were removed or left to like it was. That's one thing. And this difficulty of transit led to difficulty to keep many patients, especially ladies who still were fertile, they had, with some frequency, they had anemia, and we had to give them iron IV because they couldn't absorb well without the duodenum in transit. And also problems with the protein absorption because they didn't succeed in eating beef, for instance. And we had to replace it with some other artificial protein. Then we gave up, and it coincided with the time when we left open bariatric surgery to laparoscopic surgery. The pouch was reduced to the size above the ring, and the anastomosis around 1.5 to 2 centimeters diameter. All the rest the same. We had a study, just a sample. By the time we changed, we studied 200 cases before we left the ring and 200 after, and compared after 5 years. Tried to. Only half we succeeded to have data after 5 years. And out of those, some of the ring group had no ring anymore. We had to take it off because of slippage or erosion. But mostly they were groups around 100 each. And what we found, there was no significance in excess weight loss at 5 years. There was not significance in nutritional data. There was not significance in reduction of comorbidity. So quality of life was better. We had less need. That's not proved. It's just an impression. We didn't study that. We had less need to supply iron and protein other than by diet. But we kept having around 10, 12% weight regain. So it's a similar experience. Bypass is excellent. We think that in our environment, because of problems with follow-up, with access to good assistance when you have some complications or difficulty, we prefer to use presently non-banded gastric bypass. Our group with 8 surgeons completed 25,000 bypass procedures December last year. Of course, many of these we never saw anymore after a few months after the operation. But we have a lot of people coming back every day to the office, and we have, let's say, a good personal impression about that, although we cannot prove with solid data. So I think that's what I would like to comment. And I ask the panelists if they still want to comment on, like Dr. Greve has a lot of experience on bariatric surgery, and he talked to little. How about that?
Oh, I like to talk a lot more after. No. One major problem I see in your results is that you are comparing the surgery from the open era, which is completely different from laparoscopic surgery, and you used a very, very small ring. And that is where the big problem is. Yeah, I know, but even at 6.2 centimeters, it is too small. The ring is there, as Mel Fobi correctly pointed out, to prevent dilation of the pouch, not to cause restriction. And we even found that using the Mel Fobi ring, which was 6.5 and 7 centimeters, it's different from the other rings that you can use. For example, the minimizer ring. When we now use the minimizer ring, when we use a minimizer ring at 6.5 centimeters, it's too small because the size is different when it's closed compared to the other ring. So the size is extremely important, but it should be very wide. It should be loose around the pouch. And then you will get the results that we see also on the long term with low complication rates, with very few patients regaining weight. And that is a very important issue. And of course, it's extremely important to teach your patients properly. Like Mel also put a lot of, a big part of his presentation on how to teach your patient, because that's another thing. The patient should realize with any type of procedure, but in bended procedures in particular, that the way they eat is extremely important. And when they are not able to change that, then of course you have a problem, but then they will have a problem with any other type of surgery as well. So I think I've taken enough time now, but
I'm entirely agree. I'll like pass the word to you, Dr. Fobi. I entirely agree with you, but what we observe is that the patients who regains weight, this patient doesn't eat hamburger, he eats sugar, or he drinks alcohol, mostly, almost all. You can't prevent to eat sugar with a ring. That's the problem. And although we try to educate before the operation, and each time they come to the office, you know that they tend to go around what we teach. So it's all correct. I think the ring must be in the long term, and we are trying to find data about that at 10, 15 years, a little better in terms of regaining weight. But not a big difference, I would say, in what we see in our impression. Dr. Fobi, what do you say?
Well, let's go on now and see how the procedure is done technically. Dr. Bhandari would do one of the cases, and then we can follow with more comments. Are you there, Winnie?
Yes, sir. Yes.
I have the moderators for the live surgery, and let's go on and then we'll follow up with the panel discussion afterwards.
Sure, sir. So thank you, Dr. Cazzo, for your presentation. And now I would like to invite Dr. Greve, who will just reintroducing him, who was the past president of IFSO, one of the founding members of IFSO, and he's also the co-founder and past president of the Benelux Association of Bariatric Surgery. So he'll be one of the moderators for the live surgery session. Along with him, I would like to invite Dr. Khaled Gawdat, who is also the founder of Egyptian Society for Bariatric Surgery and is a pioneer of morbid obesity surgery in the Middle East, introducing obesity surgery of Egypt from 1996. And Dr. Mahendra Narwaria, who will be one of the moderators for the live surgery session. And I welcome you all. And now I would like to ask Dr. Shashank Trivedi, who will be presenting the case details. Dr. Shashank.
Thank you. Hello everyone. Today we have a 40-year-old gentleman with a weight of 135 kg and a BMI of 44.6. He is a non-vegetarian by diet and is a known case of diabetes mellitus type 2, and he is insulin dependent for that. On the biochemical profile, the albumin is 4.3, HbA1c is 7.5, and he's negative for COVID, HbSAg and HIV. The USG showed grade 1 fatty liver.
Thank you, Dr. Shashank. And now we'll be going for the live surgery to Dr. Mohit Bhandari.
Okay, good evening, everybody. I hope you can see me and hear me. So, as you can see here, we will first perform an endoscopy on this particular patient to rule out if the patient has any other problems like a duodenal ulcer or a gastric ulcer or a polyp, which we need to take care of. This is the Z line, and as I can see, it looks good. Now, once I enter inside the stomach, I can see that there is no gastritis. I cannot see an ulcer or any gastric polyp. This is the pylorus here, and as I can try to enter inside just to have a look at the duodenum. So as you can see, this is the duodenum here. I'm into the second part, third and the fourth part of the duodenum. I don't see any pathology, but that would be more pronounced when I pull my scope back. And here I can see that absolutely normal duodenum. So there is no pathology in the duodenum. Now I come inside the stomach, and once I'm inside the stomach, I can retroflex my scope, as you can see, and identify if there is a hiatus, but I see everything is normal here. The G junction is at 40 centimeters. So I would suck all the air possible and would pull my scope out. Now let's talk about the port position. So this is the endoscopy which we did. Let's talk about the port position now. So as far as the ports for this particular procedure are concerned, I would ask the camera person to focus on the ports externally. So as we can see, we have one optical port which is just above the umbilicus. There is one 12 mm port on the right side of the umbilicus in the anterior axillary line, which would be used for me to fire all the staplers. There is another 12 mm port on the left side of the umbilical port in the anterior axillary line. There are two 5 mm ports, both in the anterior axillary line, 2 finger breadths below the subcostal angle on both the sides. So total 5 ports, and we have inserted an Athanson's liver retractor to retract the liver. Now let's have the endoscopic view, please. So as you can see that this is the endoscopic view, and we have a nice stomach here. I would make sure that we do not have any hiatus or anything, and absolutely no hiatus. Normal stomach as far as I can see here. Now, once I have done this, I would start with the first step of the procedure is to divide the omentum. So this is quite a big omentum here which we need to divide because when we do an anti-colic, anti-gastric anastomosis, this omentum can come in our way. So you can see that this is quite a large omentum which we need to divide, and quite thick as well. We have stopped performing retrocolic gastric bypass at our center for the simple reason being that it's challenging once we have to revise these gastric bypasses. So we actually stopped doing them. It's more challenging for a surgeon to revise most of these gastric bypasses when they are done by the retrocolic route. So we have chosen the anticolic route here, and This is the omentum which we need to divide. I would usually start to divide just parallel to the falciform ligament and try to go towards the left subcostal area, dividing all this omentum away. When the omentum is thick, sometimes we can use vessel sealer, but here it's good. We are very satisfied with the harmonic, but if it is thick and there are vessels which start to bleed, we can go ahead and use a vessel sealer also.
Dr. Bhandari, do you routinely divide the omentum or just in
No, we routinely divide it because yeah, not in mini gastric bypass, but yes, in gastric bypass we routinely divide this omentum.
In our practice now, we're being selective. We just, if it's a very big and thick omentum, we do that, but for thin and nice omentum, we don't have to.
Yeah, I mean,
yeah.
It also depends. Yeah, you're correct. You know, sometimes, mostly when I'm revising a sleeve to a banded gastric bypass, I find that because of a loss of a lot of fat, the omentum becomes very thin. So you are correct that we can be selective in those cases. But here, what I'm seeing is a lot of omentum pad of fat, which can cause problems for me later on. So I'm just trying to be more conservative and trying to be a little more aggressive and divide it rather than being conservative in dividing this omentum. So this is the transverse colon here, and we try and stay a little away from the transverse colon because I have seen injuries happening here when we go very, very close. So we don't completely, skeletonize the transverse colon of the omentum, but quite a bit of distance away from that particular part. Also, I think my way of doing this gastric bypass is a little different than most other surgeons because we would usually not do a loop anastomosis. We would do an end anastomosis, and when we anastomose the loop as an end, it puts more pressure because we don't have that freedom like most surgeons who would do a loop anastomosis to modify the loop according to the pressure on the omentum and take a loop which is maybe a little distal to the original one. So that's how we divide it. And now this is how we place it. So you can see that now the patient is completely supine, and this gives a nice view of the ligament of Treitz and the inferior mesenteric vein. So you can see this ligament there, and we can also see inferior mesenteric vein sometimes when the patient is thin enough, like for example here. So that's the Treitz, and we're going to count around 80 centimeters from here. So it's mostly using this grasper as the marker. So this is 30, 40, 50, 60, 70, and 80. So that's my length of my BP limb in most of the banded gastric bypass. Around 80 centimeters is our biliopancreatic limb. Most surgeons have gone very aggressive with this BP limb, but I'm still conservative because we are bending this procedure, so we don't want to combine malabsorption and restriction in one go. So I think it's better to be conservative with 80 centimeters of a limb here. And specifically, this patient is not that high a BMI where we need to be more aggressive. So I'm being a little conservative here.
Dr. Mohit,
yeah,
do you really think that you're so conservative? You're doing a banded bypass, and we see in the Netherlands that many surgeons use the so-called elegance, which is the long biliary limb bypass.
Mm-hmm.
But our results are with the banded bypass with a standard room Y are better than this long biliary limb bypass, which, by the way, I don't think will give any absorption.
Even in our case, when we have done banded gastric bypass, our results are much better. So I also follow the same principle. I follow the standard gastric bypass, which is practice of limbs, and we don't do this long limb. No, that's fine. So this is the distal limb, and this is the biliopancreatic limb, and this is the elementary limb, which I marked with a clip. And now I'm going to count another 100 centimeters from here. So this is 3, that's 4, it's 5, 6.
Can I ask you technical question. You're standing on the right side of the patient.
7,
Do you prefer that over
8,
in between the legs?
9, 10. Yes, I usually stand on the right side of the patient instead of standing between the legs of the patient. And that's a convention we have been following in all our procedures, and the assistant stands between the legs of the patient, so it gives me a little bit more space to move around. Now there are two reasons why I can do that apart from many other surgeons. The first reason being that I understand that so this is the elementary limb which is marked with a clip, and so just that we do not make a roux and O, and this is the biliopancreatic limb. Now coming back to your question, why standing on the right side? First, it gives me more space. Second, I don't need to stand between the legs because I use a endo stitch in most cases to close most of my defects, and that's why we don't need much triangulation. Endo stitch can be worked while standing on the right side of the patient also. That's the benefit of using the endo stitch. So most cases we would not need to triangulate that much. I think if we are using the conventional suturing, I have seen surgeons are more comfortable standing between the legs of the patient. So that's the second reason. The third reason is that when I approach this jejunostomy and closure of the internal hernia defect from the right side, where I am standing now, it's much more easier for me to perform this procedure. So these are the three reasons why I would prefer to stand on the right side rather than between the legs of the patient.
And this is a anti-peristaltic anastomosis you make, or is it isoperistaltic?
Yeah, it's an isoperistaltic anastomosis, and I'll just demonstrate you the three limbs. So this is the elementary limb here, and we can follow it back. So you see my camera is going up, back, and we come directly here. So this is my elementary limb, and so you can see I followed it up, back. This is gonna be my common channel. So this is the continuity of the common channel, and this is gonna be my BP limb. Now I'm gonna
that is anti-peristaltic. It's not isoperistaltic.
No, let me close this, and then once I take the Brolin stitch, it becomes isoperistaltic. Let me close this. So
Dr. Narwaria, would you like to comment?
Yeah, I think I do the same technique what he's demonstrating, and only thing difference is I take 100 centimeter limb and 100 centimeter or 120 centimeter of elementary limb. Rest otherwise everything is same. I used to do bended bypass years ago, like almost 10 years. I may be the first one to start in India, but nowadays I do less because my MGP work has gone very high. So I don't do bended bypass now. Very, very few patients when I'm doing revisions, yes, I do bended bypass.
So Dr. Greve, this is what you are talking about. So now this becomes a isoperistaltic segment. Can you see this now?
Yes, but your anastomosis is anti-peristaltic, and I think that's the important thing on the direction of the peristalsis of both loops.
So this is the elementary limb, and it gets anastomosed there, and if the food's gonna come here like that, following this track, and it's gonna go this way.
Correct.
That's the common channel. Yeah.
Oh.
So, Dr. Bhandari, you would not change the limb length if the patient is diabetic or not? I mean, if we're doing it for weight loss and metabolic, and the patient is diabetic, you would not consider elongating your BP limb for that?
So
not only diabetic, even super obese people, we need to have a long limb, right?
So I think if there would be a super obese patient and he would be severely diabetic, I'm not going to do this procedure. We have our own algorithm where if we have a super obese patient with very severe diabetes, we choose a mini gastric bypass with a BP limb of 180 to 200 centimeters. So you are correct. And if at all we have to do a gastric bypass, yes, our BP limbs would be 150 to 180 centimeter in that particular case. But I feel more comfortable in doing a conventional mini gastric bypass rather than doing a banded gastric bypass in super obese patients. It's a
So,
shorter procedure as compared to.
You took a bursting kind of suture here?
Yes,
At the base
yes.
of mesentery?
Yes, yes. I took
Otherwise, what I do when I take the Brolin stitch, I follow from there below towards the base.
Yes. We also started doing that, but I found that now you see this base here. It's much more secured. So
Mohit, sometimes it can cause some tension on the mesentery. It causes crumpling on the mesentery when you're taking it up.
So that's the reason that I'm more cautious here, and it has never happened to us that it has caused any tension. So and that's the reason why we always mobilize the omentum so that it does not have tension on the root loop. So yes, I kind of agree with you, but if we are cautious, then it does not cause any tension on the mesentery. The problem what I face starting from the kyphelate to the caudal end is that sometimes we lose micro defects on the base of the mesentery, and those micro defects can be a little problematic. So instead of solving a problem, we create one. So that's why it's a convention which we chose not to start from the top but to come from the bottom. So we modified the original technique by Phil Shower and his colleagues, and then even the colleagues from Cleveland Clinic now modified this, where now they started closing the base first because they thought that if they come from the kyphelate end, they created more micro defects in this particular technique. So that's why we just changed our technique. I used to do the same, like you said, as a convention, but then we stopped doing that because we thought that maybe it creates more micro defect, and we could appreciate that we were not able to close it because that purse string causes a good closure of the defect. So as you can see, this
technique is good when we are doing an omega loop first and then dividing the loop and bringing it down. That time, I think this technique works.
So you can see that this is a closure of the internal hernia, and we have a nice common channel here, and this is the BP limb, and this is the elementary limb. Now I'm going to go towards the supracolic compartment, create a pouch, and then put in a band. This omentum has to come down.
How about the Peterson space?
So Peterson space we'll close, but first we need to do a gastrojejnostomy, and then we better appreciate the Peterson space. In anticolic anastomosis, it's much more easier to first make a pouch gastrojejnostomy and then close the Peterson space. That and I'm going to do at the end once my procedure ends. So this is a pars flexira technique. Now we initially started with the perigastric technique of creating an entry into the lesser sac, but then later on I switched to the pars flexira because I did not see any difference in terms of my results, but this takes lesser time than the perigastric approach, and I convinced a lot of surgeons who were doing a perigastric into a pars flexida when they saw this technique which I performed. So it's just that you need to just retract the left gastric pedicle a little bit, and if there is some oozing, we can obviously take a sealer which can help us to prevent this oozing. There are big vessels obviously here because there is a lot of fat. This patient is not a very good candidate for a gastric bypass, though I would have loved to give him a mini gastric bypass, but he doesn't have that severe a diabetes. So as per our algorithm, he gets fit for a fitness for a gastric bypass. Now, as you can see, I have retracted the left gastric pedicle, and we are close to the base here, close to the stomach base, and I'm just cautiously using some bipolar energy to just take care of these fat pad close to the gastric wall. At most times, I would see a small vessel here. So you can see that
bipolar is better here. I said, bipolar is always better in this portion because we don't need staples, and you can easily cut it with the using, and there's less bleeding and less smoke, which is generated in harmonic.
So this is not a harmonic. I'm using a bipolar only. This is a bipolar device.
Yeah.
That's what I'm using. Sure. Yeah. Give me a stapler. So I agree that we usually would not use a lot of harmonic if the omental pad of fat is thick here, and that's what I'm trying to do. I'm not using harmonic, and this is one horizontal fire with a blue reload, and as you can see that I'm not using the entire length of the reload, but we use just 4 to 4.5 centimeters of this reload.
Or after the first vessel from the left gastric?
Yeah. So now, as you can see, we have to band this pouch. So as Dr. Fobi was saying, that the pouch has to be for a breadth of 2 centimeters, and that's what is important. So we're going to make a very thin pouch. I would want the tube to come in now. As you can see, the tube is inside, and at this stage we would want to go a little more closer to this pouch so that we create a narrow tube, and this is 2 centimeters exactly, because push the tube, push the tube, push the tube, push the tube, push more, keep pushing. Okay, so you can see that there is a little bit of fat on this pouch, and before I go further, I would like to delineate this anatomy a little bit, just for the sake of demonstration, so that we understand where we are trying to work. And there are small vessels here, so I'll be a little slow because these vessels often bleed. And now we can see a nice anatomy. So that's it. This is the posterior wall. There I can come in with a stapler, but before I do, I can do a little bit of dissection here, maybe mobilize this gastrophrenic pad of fat. Usually this pad of fat, we can dissect through it and make it leaner at this site, so that once we come in with our stapler, we don't need to do a lot of dissection here. So that's it.
Mohit, I do this step first when I start the process, and I use
Push
a gold
the
finger to dissect
push the
it
tube,
further.
keep pushing, keep standing and keep pushing. Okay, yeah, we can, that's a part we can do whenever we want. So, that's the step, that's the dissection which can be done by a blunt grasper. Most surgeons use a gold finger here or different other devices. Usually we avoid using that. If need be, we can use that if we do not get a good amount of exposure, but I usually get a good amount of exposure there. So as you can see, since there is a lot of fat, I'll use this cartridge here to dissect this particular pad of fat, and also do some retrogastric blunt dissection. So instead of using the harmonic, I do some retrogastric blunt dissection like I did with my grasper, and then what we can see is the cartridge easily comes out. So you can see that that's my cartridge, and I can just articulate it to dissect. You can see I'm dissecting it with my cartridge, and there's a thick pad of fat there which I can take care of by just dissecting. So now you can see that my cartridge is all around that, across my fundus of my stomach, and that's completely separated. So that's the technique. We can do a blunt dissection, or we can use a harmonic at that particular area. Both the choices are ours. Whatever we want to use can be used. I would see if I need to use another cartridge to sort of dislodge, but I know that the staple line has gone across. All of us have seen that, but still would see if I need to fire another cartridge just for the sake of separation, or I can, usually you can see that this has gone across. We don't need to use any special cartridge or anything there. I'm just going to use the energy source and cut it apart. So that's it.
How far you stay from the esophagus?
So this is around 1 to 1.5 centimeters. So this breadth and this, so around 1 to 1.5 centimeters from the esophagus. We do not dissect the esophagus. Push the bougie, keep pushing, keep standing and keep pushing. So this is the perigastric space which we would need to create. And while I create the perigastric space, I put all this omentum and stomach below the stomach so that we are easily able to see and it does not come in our way. Now, this particular area is the perigastric area where very little bit of dissection can help in creating the space. So as you can see, I'm across, and then I can do a very simple maneuver of just dissecting this pad of fat over my grasper so that my ring, which I'm going to insert, does not have a lot of problem. So this is a very little pad of fat over the grasper, which we can easily dissect. And then dilate it. So this is a minimizer ring which we use. We were using a gap key ring previously, but since the production has stopped and it is again going to start, now we are using the minimizer in the meantime. And this is the minimizer ring. The beauty of this ring is, again, we have the freedom of calibrating the ring on table. So we can have sizes ranging from 6.5.
So Mohit, the new GABP ring which you're talking, will that be Indian origin or American origin again?
That I think Dr. Fobi will answer. So this is size 7 and it is loose with the bougie in. And now I'm going to cut this particular ring. So you can see that there are slots here, 8, 7, 7.5, 6, and we can go further tighter on these slots. So I will stay here at 7, size circumference 7, because I don't go more tighter. This particular pouch, can I have a ruler, please? Can I measure the pouch, the breadth at the length?
Dr. Bhandari?
Yes.
I think you make a 7.5 centimeter ring, but which is good in male patients.
It is 7.5. Yes, perfect.
Just a minute. I'll just check it again.
Yeah, but 7.5 is
okay. It's a 7.5. Sorry.
Yeah, it's fine.
Yeah.
But what I'm worried about now, how will you make your anastomosis? Will it be a linear stapler, or will it be hand sewn? Or
no, it would be a linear stapler. Would be a linear stapler.
Are you not afraid that you will be very close to the ring with your anastomosis?
No, it won't be. It won't be. I'll show you. So this is around 7.5 centimeters of a pouch, and the breadth, the length is 7.5 centimeters. The breadth of the pouch, as we can see here, it should be around 2, but let's measure it, because we feel that it's 2, but in laparoscopy everything looks big. Yeah, you can see it's around 2 centimeters. And also you corrected me because I have come on the second slot here, so it's 7.5 on the ring. Now I can make, just push, keep pushing and be there. Keep pushing, keep pushing, keep pushing. So this is the bougie, and what I'm going to do is make a gastrotomy, a small one, over this bougie. Okay, now as you asked about the question of doing the anastomosis, so I'm going to take around 4 to 5 centimeters away from the staple edge. I'm going to make a small enterotomy here. And now about the chances of having a short anastomosis. So as Dr. Fobi said, our aim is to make minimum of a 2 to 2.5, if not more. So you can see that this is my cartridge.
The diameter of anastomosis doesn't matter when we are doing banded bypass, because anyway the ring will take care of the anastomosis, the stoma size.
So that's what I'm saying. That
so we can have little larger anastomosis here.
Yeah, but the diameter matters, because we cannot have a smaller though. So which means that the diameter matters.
No, it should not be smaller. I mean, it should be definitely more than the ring.
Say it can be a little larger. So I agree. Yeah. So you can see that it is 4 now, and I'm going to calibrate it. I'm going to bring it to around 2.5 to 3
centimeters.
You can see this is now fine. We are at 3 centimeters. Now I'm going to take it 3 because when I suture it, the technique which I use makes it 2.5. So that's fine. So that's why I made a little larger anastomosis as far as I'm concerned. It's around 3 centimeters to start with, but it becomes 2.5 by the time we start to suture. So this is a conal suture which we will take. We can take the suture outside the anastomosis, but conventionally the Phil Showers technique which we follow has been practiced for years together, takes it inside. So that gives us the freedom of securing the corners in a better way. So we before taking the conal suture, we take 1 stitch inside, and then I'm going to follow this entire technique by taking 1 or 2 throws of conal suture, just to secure this particular angle at the caudal end of the anastomosis. So this is the scope at 30 degrees, which is showing the angle clearly. A 45 degree would have shown the angle much more in a much more better way.
I think you're using 3D, right?
Yeah, I'm using a 3D, but it's 30 degree.
Yeah, that's the reason we have 30 degree.
Yeah. So, but it's manageable. I can say that we are able to see a good vision, as you can see here. This is the angle.
3D we can manage.
Yeah. So the advantage is 3D is that you can manage with the angles, because there is a good depth perception.
True.
so this is the nice angle, as you can see, which I secured. And now I have secured the caudal end. I'm going to cut this. So I'm going to do a single layer anastomosis. I know for Dr. Narwaria and some others who use this as a 4-layer anastomosis, and that's what I do. So this is something which we started doing a 4-layer, and then we shifted to 1 layer. So we thought that maybe the other layers are just redundant. Once we followed this technique for a longer period of time with 4,000 gastric bypasses done, we thought maybe we can manage with a single layer. So this is a absorbable suture, Vicryl, and it's known as a polysorb because we are using a Medtronic endostitch device. So the suture comes by a different name. I can say that this candy cane which you see is not a very large one, and I'm not much concerned with this candy cane because in any case we have banded this particular bypass. So that's what is the point which we are trying to make. The length of the anastomosis or the length of the bowel distal to the anastomosis would become inconsequential because we are banding the bypass, and that's the beauty here. So the ring is going to form some adhesions over a period of time, and these adhesions which will be formed over a period of time will basically create a fibrous capsule and will not allow this pouch to dilate, is what we postulate. So
we have a question from the audience, Mohit, concerning the pars flaccida technique where you divide all the vessels up to the stomach. And the question is about the nerve, because when you do this, you add a vagotomy to the procedure. So are you concerned about cutting the nerve there, or was this any consequence for that?
So when I started with the perigastric technique and when I saw surgeons doing this, I was concerned 10 years back. But now, having done around 4,000 procedures with this technique, we are not concerned because we do not see any difference between this. And you know, in our technique, in our center, other surgeons can perform perigastric, but we don't see high rate of, in fact, the marginal ulcers should reduce. The only problem that can happen in these cases would be a poor rate of gastric emptying, and which does not happen. There are high incidence of diarrhea. No, it has never happened with patients because of vagotomy. So I'm not finding problems. And this is a partial vagotomy, not complete. So I'm not finding those problems, and we continue with this technique because it is simpler, easier, and manageable. The other downside can be, so this is the Peterson space, which I was asked by Dr. Garrido about closing, and this is a large space. So I'm closing this space with a...
Do you close it routinely? Because I don't use this closure, and I never had Peterson hernia.
No, I close it routinely in each and every case, and I had Peterson's hernia, so I close it. And closing it makes sense because it's not a very time-consuming process, as you can see. We just need to expose this defect, and I can tell you that using an endostitch as you use, closing this is more easier. It's just a 2-minute task. So it's better that we close it. I had 2 Peterson space hernia, one before Dr. Fobi joined me and other in front of Dr. Fobi. So I think that there is a certain incidence of Peterson space hernia, and they should be closed. I think Dr. Garrido can comment on it. He has an experience of 15,000 gastric bypass, and over 5 lakh gastric bypass have been performed in Brazil. And for the one surgeon I have heard most is Almino, who does maximum number of them, and they almost close all these defects. So I think it makes sense to close them. If we also
close.
If we leave them, we are exposing a potential space for a problem. So, you know, it doesn't take so much of time to close it, as you can see here. So I'll again demonstrate the anatomy. I'm still to fix my ring with a non-absorbable suture. So I'm going to fix up my ring there.
Oh, regarding the Peterson space, we also close it, and we have seen quite a number of hernias in Peterson space. So, Mahendra, I think you should look at your patients more carefully. You will have hernias when you don't close.
Okay.
We had bigger problems than that being undiagnosed, because I have seen gangrene in one of my patients who went to some other center, and that was a disaster. So and that patient could not be saved. So as Dr. Greve says, that we are all surgeons, and the experience of
Mohit, is this a V-lock now?
no, this is normal silk.
Yes.
Why not using endostitch at this stage?
No, I could have used it. I don't want to waste a suture. That's it. So
Just a small comment on this, Dr. Mohit.
Yeah.
Silk is a resorbable suture. It takes longer, but it does resolve. It's a natural fiber. You should use Prolene or something, I think.
Okay. Yeah, we have been using silk. We can use Prolene. I agree. Prolene is more permanent than the silk. So this is a silk. The most we have used is a Surgideck, which is Ethibond by the
that's also
Medtronic. So, but that's fine. I mean, as long as we use in any case, in 3 to 4 months, this ring, it forms a nice fibrotic band. So now I can come in with an endoscope and I can demonstrate. But
before you go there for that, let me just point out a few things before you go. Look at the ring. Dr. Garrido, you can appreciate what we mean by a loose ring. You see how loose that is?
Yeah.
Yes, but I ask you something. How do you prevent the slippage in the front face, in the anterior face?
Well, you're making a 3 to 4 centimeter pouch. You go in perigastric, so that part of it restricts the ring from slipping down. And then you put a non-absorbable suture on the anti-mesenteric point, which is the staple line. And for the gastric bypass, we have not seen much slippage.
Yeah, no migration seen by yourself.
Yeah. And I wanted to point out, you see, that is different. When I first described the banded procedure, I was putting a ring around the pouch like I did in the VBG. And those who learned from me at that time did the same thing, and that's why they had a high rate of erosion and food intolerance. Then with my friend from New Zealand, who did a lot of studies, we found out that we can make the ring looser. So now we use mostly 7 to 7.5 centimeter, like Dr. Bhandari has shown. And the patient only feels it when they eat a big bolus of food. Okay, Dr. Bhandari is going to be doing an endoscopy.
So this is the endoscopy, and as you can see, we are inside the jejunum now. So this is the jejunum. This is a small sort of a candy cane, you can say, very small here. This is the anastomosis, as you can see. This looks good, nice and wide. And what I was trying to say is it is around 2 centimeters, because we sort of do a little bit of inverting of the serosa when we do this anastomosis. So this is small. Now this you can see from the top. It's not as big. It can barely accommodate my scope, which is 1.5 centimeters, 1.2 centimeters in fact. And it's a single lumen scope. This is the bowel. This is the candy cane, the small one. This is my anastomosis. You can see a vicryl suture there. I come back and now I measure the length of my pouch again by using the endoscope. So I'm here at around 55. I pull it back and I come to the GE junction, and this is say around 45. So 42. So this is 42 exactly. So
I mean 45 to 42.
48, sorry. So this is again, so this is the anastomosis, and here is a staple line. I find a minor ooze here, but that's not actively bleeding. And now I'm here. I'm going to suck this, completely going inside so that I do not have a problem with my anastomosis in my stomach. And once I suck this, I can see that the assistant can release the cartridge, and that can help the carbon dioxide to pass distally. As such, we are using the carbon dioxide here to dilate this bowel for the purpose of endoscopy.
Mohit, do you do the leak test?
No, we don't.
Test or methylene blue or anything?
We don't do leak tests. No.
Yeah, even I don't do that. But
Dr.
I think the junior surgeons who are doing, I think they should.
So we stopped doing leak test. We stopped doing a 4-layer anastomosis. We stopped we do an endoscopy post-operatively just to check bleeding inside. But we stopped doing leak tests.
This is one thing which you added.
Pardon?
That is new thing which you added. Most of people, they don't do endoscopy after the procedure.
Yeah, so
Before
this,
is okay.
this
But
we started doing of late when we wanted our fellows to understand the internal anatomy of the gastric bypass or mini gastric bypass or sleeves. Also because they need to be familiar with this anatomy, because we do a lot of these bariatric endoscopic revision procedures. So they need to understand the landmarks about the anastomosis, the way it dilates, what does the anatomy looks like. So we started doing this. That's it. So thank you very much. I will be
Dr.
back.
Bhandari,
Yes.
about endoscopy, do you perform endoscopy before the operation?
Yes. So we perform the endoscopy before the surgery on table, but not.
No. What if you find a peptic ulcer or hernia?
Yes. So we take a blanket consent from all our patients that we can change the procedure on table. So we don't commit to a procedure till we are inside. If suppose we have a hiatus hernia, we don't do a sleeve. If we have a peptic ulcer disease, the ulcer
Do you
is
still use the band if you have a hiatus hernia?
Yeah, I would definitely use a band. I would repair the hiatus, pull in the esophagus down and use a band. We don't think that the bands increase the rate of GERD or increase the incidence of hiatus hernia. We have been using bands in patients with hiatus hernia if we perform a gastric bypass.
I think it will dilate. Some kind of anti-reflux posture has to be combined if we are using a band below the hiatus, because we need to create a hiatus and then we can put a band. Like I do fundoplication using the remnant stomach if the hiatus hernia is significant large size. So
we don't do a fundoplication, but we'll pull down the esophagus, repair the hiatus, repair the crus, and then we put a band. And we haven't see, at the end of the day, what we believe is that the hiatus will give symptoms if the length of the intra-abdominal esophagus is less than 2 centimeters. So we make sure that we have around 4 centimeters of intra-abdominal esophagus, and then I don't think there is a need for a fundoplication. We don't have enough experience with that, but as Dr. Narwaria said, he does a fundoplication
using the
remnant stomach. Yeah, so that's something which we don't do.
I would like to listen from all the panelists about what to do when we have a hiatus hernia.
Well, I would do exactly the same as Dr. Bhandari. I would repair the hiatal hernia, and then I just use a band as well. And I don't do a plication.
Repair the hiatus, or you do a fundoplication?
No, I repair the hiatus. And you have to mobilize the esophagus to bring it in the abdomen for at least 4 centimeters. Yeah.
Dr. Gawdat.
I think adding a fundoplication here is a formula for that could stimulate gastrogastric fistula later on. In the primary procedure, I usually cover the distal stomach and put it away from the staple line, because adhesions between the two staple lines can initiate a gastrogastric fistula. So to my mind, adding a application with the distal stomach, that is a recipe for a gastrogastric fistula. So I would just open the hiatus, close the crura, and maybe fix the pouch to the crura, and then put it.
Dr. Cazzo.
Hi. We opt to close the defect, but we do not place band in these cases.
Yeah, same here. I don't put band if I see a hiatus hernia, and if at all I'm doing it, then I'll do fundoplication on it, and then I do it. And those patients who are having esophagitis in a pre-operative diagnosis, and I'm doing a gastric bypass, I still prefer to do a fundoplication, because sometimes it can be alkaline esophagitis. Even in spite of gastric bypass, they can have reflux.
Dr. Fobi, tell us.
Well, I do not mess with the gastroesophageal junction. Doing anything to that junction when you have not done studies to show that there is decreased lower esophageal sphincter is just making yourself comfortable. There's no science to it. So basically, if you are going to do a hiatal hernia repair, because you have a large hiatal hernia, I can understand. In that case, you have a hiatal hernia defect that is 4 centimeters or more, and then you're doing a hiatal hernia repair, but you're not doing that as an anti-reflux operation.
Yeah.
A cross repair has never been there for anti-reflux, and many bariatric surgeons don't understand that. But you can have a hiatal hernia which is not reflogenic if you have a good lower esophageal sphincter. So what I do is, if I go in normally, I do the endoscopy. If I don't see a hernia and I go in and I find a large hernia for some reason, then I would repair the hiatus and I'll do the same banded gastric bypass. If the defect is less than 4 centimeters, I just go ahead and do a gastric bypass and leave that esophageal junction alone. I have learned from the sleeve that if you mobilize the gastroesophageal junction, you're promoting the sleeve to slide into the up into the chest. And I see a lot of surgeons doing that, and they come to meetings and present that esophagus, the gastric pouch in the chest, and they went and destroyed what nature had put there to keep that pouch down. But that's just my opinion, and having traveled to a lot of centers and observed a lot of surgeons.
Don't you think the band will increase the reflux if you have a hiatal hernia?
Well, we've been looking at that very carefully. You see, what is reflux? There are 3 things. There is vomiting, regurgitation, and reflux.
Yeah.
Reflux is when you have the gastric content going back into the esophagus. When you have a 3 to 4 centimeter pouch, you don't have anything in that pouch to go anywhere. And now that we're doing routine post-operative surveillance, we are not seeing any gastric content or small bowel content coming into that pouch. And we'll measure all our pouches, and we're looking at the gastric bypass pouches. They measure anywhere from 3 to 6 centimeters. So they're not big enough. Well, if you end up having a patient that eats and dilates that pouch, then it becomes a normal gastric pouch and might have reflux. But if you have a small pouch, 3 to 4 centimeters in length, there's no reflux in it. That's why the gastric bypass is a refluxogenic operation. It treats reflux because the pouch is small and there's nothing there to reflux.
Have you encountered food bolus obstruction? Because in India, we get a lot of vegetarian people who get a bejor kind of thing, which is stuck on the band, and they come with the obstruction and vomiting. Sometimes we have to do endoscopy, break the bejor, and take it out.
Absolutely. Absolutely. Anytime you do a restrictive procedure, you're going to have a percentage of patients that come out with bejor. I had bejor with vertical banded gastric bypass, with regular gastric bypass, and then with banded gastric bypass. That is why my presentation was not talking so much as to the technique, as to the fact that you have to work with the patients. And what we're calling food intolerance is poor coaching. The patients are not having food intolerance. The patients are being non-compliant.
Yeah.
Because your restrictive operation requires the patient to be compliant. When you do a gastric bypass, you require the patient in the first 6 to 9 months to eat slowly, to chew their food, and to take small bites. What the band does, it forces that patient for the rest of their life to keep doing the same thing. That is called forced compliance. And that is what the surgery is. So to tell somebody you're going to give them an operation and they can eat what they want is just, it doesn't make sense. It's like doing an intestinal bypass and telling them they're not going to have diarrhea. No, when you do that, that's what happens. So that is part of the mechanism of the procedure.
So what are the complications we can expect because of the candy cane, which sometimes, though here it is a 2 centimeter, but sometimes we can have a larger candy cane which is left there. So what a post-operative problem which we can encounter because of candy cane which we left around? Because Dr. Gale has just mentioned why not to remove a candy cane if possible, even at this size.
Well, you don't see as much dilatation of that part of the small bowel when you have a proximal band.
That's true, but leaving in a part of a candy cane, which was in this procedure, it has the risk of dilating and then causing a lot of complaints later on.
Yeah.
So I would myself, I would make it a much shorter. I try to completely prevent any kind of candy cane.
Yeah, most times Dr. Bhandari doesn't leave as much candy cane. I don't know why he chose to do that in this procedure, but I normally don't leave much candy cane. I normally come right. When I do this procedure, as he would tell you, I bring the small bowel up to the stomach and do the gastrojejunostomy, and then I do my transection, leaving very little candy cane.
That's exactly what I do myself.
Yeah.
Okay.
And you can go very close.
There are two other things I want to point out. We do intraoperative endoscopy. So patients come in, we get a history and physical. If they have hiatal hernia by history or they're taking PPI, those patients don't get scheduled for a sleeve or an MGB. They are scheduled for a gastric bypass. If the patient doesn't have any symptoms, then we can schedule the patient for an MGB or a sleeve, but we do intraoperative endoscopy. That stops the patient from making 2 visits, 2 operative procedures, and we do that on the table just before the bariatric procedure like Dr. Bhandari did. What you have to appreciate here is that you do it in such a way that you don't have too much of a gastric dilatation, and then number 2, you don't have too much of a small bowel dilation. He didn't show all that, and you use CO2, which gets absorbed. And if you happen to have a little bit of dilatation, go down and inspect the small bowel, and then go proximally and do the gastric part of the procedure. By the time you do the pouch resection, that CO2 will be absorbed, and you can do your gastrojejunostomy. And the only other point that he missed to tell you was, for the young surgeons watching, when you do your LARA transection of the stomach, talk to the anesthesiologist. Tell him to move his tube up and down to make sure you don't staple that tube. It sounds like a simple thing, but if you end up stapling across a tube or a thermometer, then it prolongs the procedure, and so take a minute and talk to an anesthesiologist. I'm going to transect the pouch, move the tube up and down, and then pull it out, and then make sure it's not there. I know that Dr. Bhandari works with 3 anesthesiologists who know the routine, and they normally pull the tube out before the procedure starts. But some of you might not have that, and the tube might be there and might cause an obstruction. Now I'll let the moderators, if you have to ask any questions, any audience will go from there.
Can I make 2 or 3 comments? Yeah. So about the candy cane, the size was around 1 to 1.5 centimeters, which I measured. Dr. Fobi was correct. We usually leave around 0.5 to 1 centimeters. It was a little larger, but I never suspect a dilatation here. Whenever we have even left 1 to 1.5 centimeters, we never had a problem with banded gastric bypass. Number 2, about the bougie. So yes, we should instruct the anesthetist to keep it moving back and forth. What I usually recommend is that what I told my anesthetist, and if you would have heard it, and as Dr. Fobi rightly said, we work with a very experienced team. What I usually tell them is keep pushing on the bougie so that I see the seam of the bougie or the indentation of the bougie on the tip of the pouch. Because there is a lot of fat over the pouch, sometimes even keeping the bougie back and forth, we are not able to see the movement of the bougie. So what I instead do is try and ask the anesthetist to keep pushing and stand there holding the bougie so that I can see the indentation of the bougie at the tip of the pouch and make sure that I'm not obstructing the lumen, as there is a 38 French bougie inside. So
it is possible in a center of our own where anesthetist knows what to do, but it happened with me in one of the remote places where I was doing, though the anesthetic trained at my place, and when I asked him to push bougie, he kept pushing, and I said, no, I'm not able to see. He said, I already pushed the whole bougie. Bougie has reached to pelvis.
So you know, that problem can be solved if you touch the tip of the pouch with your grasper and you can feel that the bougie is already there. I sometimes pick my pouch up with a grasper to make sure that I'm holding the pouch with the bougie inside. So yeah, obviously you cannot tell him to keep pushing till the time you see the tip of the bougie at the end of your pouch. So that's the point.
Okay, let me ask Dr. Cazzo. You just had your professor, Dr. Garrido, said they stopped doing the banded procedures. But I've been following the work at your center there, and I see you're not only doing the banded gastric bypass, but now you're doing the banded one anastomosis gastric bypass. Are your patients not having the problems he says they were having? What's the difference? Dr. Cazzo?
We recently published an article about the banded 1-anastomosis gastric bypass on a 1-year follow-up. We have observed that there was no difference in regard to weight loss between banded and non-banded 1-anastomosis gastric bypass. But the frequency of vomiting was equal between both, or whether that is, there was no difference in regard to weight loss, but as well, there was no difference in regard to food intolerance. We could not find an answer or an explanation for this difference in regard to food intolerance.
I'm sorry to interrupt you, but that is the reason why you do a banded gastric bypass with a loose ring. You make the point very eloquently. If you put a loose ring during the first year, the size of the pouch is the same with whether you have a ring or not. And it is only once that pouch starts dilating that circumference meets the ring. And so when you have a patient who has a 1-anastomosis or a regular banded gastric bypass, 2 years from today, if you put them side by side and give them the same food, the one without a ring can take more food and take more solid and tolerate better meat. But the one with the gastric bypass cannot tolerate the meat or the rice as well. So if they want to eat the meat or rice, they have to take their time and take a small bite and chew it. And I can tell you, I'll give you an example. You talk to somebody who had a banded gastric bypass. I eat meat, but I eat privately because many times I chew it and I spit out the chaff. And I have been doing that for 9 years because I love meat. But it's difficult to eat a large piece of meat and swallow it when you have a banded gastric bypass. So I understand when people have intolerance. That is the nature of the operation. And the patients have to understand that. And I'll tell you, having done more than 3,000 or 4,000 banded gastric procedures, and then we've done about another 1,000 here at Mohit's clinic, we've had only one patient that has come back and requested a band to remove because they cannot tolerate eating. And when you look at those comparative studies that you were quoting, Dr. Miguel had a review of the system, and so did you. They will say, yes, patients have intolerance, but the quality of life is the same because no patient who has a band is coming to request that you take it out because they know that they are throwing up because they did not comply. And they know if they comply, if they take it out, then they can eat, and when they eat, they're going to gain weight. But I would like to know, have you had any patients that came and requested that ring to be removed?
Dr. Fobi, Dr. Bhandari, I would like to thank you for the opportunity. Unfortunately, I have to leave to the OR.
Yeah, but Miguel, have you had anybody come back and ask for the ring to be removed? Because they can't eat meat?
In our series, we had 2 patients that we needed to remove the ring.
But they were anatomically okay?
Yes.
All right, thank you.
Thank you very much.
Thank you very much. Dr. Garrido?
Well, okay. Yes.
All right.
The problem is mainly in fertile women. They lose blood every month. So they need meat more than us. And that's an advantage of not using the ring. And most of our patients, 2 to 3 times more than men, are women. So that's a point.
Are you saying you have more anemia in patients who are non-banded gastric bypass than the banded ones? Or
Yes.
is the anemia due to the gastric bypass?
Both. But gastric bypass is not only for lack of iron or red meat, but also B12 or several reasons. But yes, I'm sure we can prove that with data, but I'm sure we have less anemia and less low albumin, especially in women without ring.
Yeah, to answer your question, that is why at Mohawk we have an algorithm. In young fertile women, the operation of choice, except if they have GERD, is a banded sleeve. We don't do a gastric bypass because bypass, banded or not, is prone to anemia, and we see that in our patients. So we recommend a sleeve in those patients, and if we do a sleeve, we do a banded sleeve, and they get very good results. What was your experience in Gawdat and I know you're in Cairo. You guys eat a lot of meat in the Muslim world.
I think when we adapt that technique that they eat more frequent meals, they can consume reasonable amounts of proteins. Maybe fish, maybe chicken, less meat, but then they are able to consume enough amounts that sustain them. We have not seen this issue of anemia here and there. But my comment on Mohit's placement of the ring is that I see probably he uses different sizes for different patients. My strategy is to use a fixed size for all patients. So when he does he use the closure at 7.5, and when does he use the closure at 7, and when 6.5? So what is his criteria for selecting the band diameter? For me, I've fixed this issue by having one fixed diameter, 20 millimeters for everybody.
Mohit, the question is to you.
Mohit, are you there?
Yeah. So usually what we have decided is that for conventional gastric bypass, we go 7 to 7.5. In cases of banded sleeves, we go to 8 because that there's a pouch is a little, I would say, larger. That's by convention. So that's what we do. I have never gone to less than 7 in gastric bypass, except for the old version of Gappy ring, which used to come in size 6.5. But to be honest with you, there is a very little difference between 6.5, 7 and 7.5. So I don't know.
About 1.5 to 2 millimeters difference in the diameter.
It makes a difference.
Yeah, it makes a difference. Well,
we do a 7 centimeter in female. Sorry, Mel.
Pardon, go ahead. No.
We do a 7 centimeter in female, 7.5 in male patients, standard, and 7.5 on redo. And that's what we do.
And how about banded sleeves, Dr. Greve? What would be a choice for, or you don't do banded sleeves?
Well, we do very little numbers of sleeves. We do occasionally the banded sleeve, and then would be 7.5.
Okay.
Till I was doing sleeve gastrectomies, I used to do all sleeves who are more than 45 BMI with a band. And I used to do 7.5.
What did you get any food intolerance more than normal?
Only 1 or 2% who did it. Even in fact, 1% we had erosion also, but that is only one. One in say around 500.
Well, thank you all the faculty members. Thank the audience who are watching. We're sharing the ideas with you today, and we hope we gave you the pros and cons of banding a gastric bypass. We recommend that whatever you do, enter your data into a registry, a database, because we are in a field that is evolving, and we have to learn, and we learn every day. I want to thank Dr. Garrido for getting up early in Sao Paulo, and Dr. Greve, and Dr. Gawdat, and Dr. Narwaria for taking the time to join us. And Cazzo, keep up the good work. And I'd like to thank the Bhandari family and Dr. Bhandari for letting me work with you all. Thank you for participating in this session. And we invite you to join us next Monday, at what time we'll be talking about the banded sleeve. Over to you. Thank you all very much.
Thank you.
Thank you.